It's November 14th, 2025. This is the Room Now podcast. Hi, I'm Jack Cush with Room Now. This week, good news on Sjogren's, good news on treatment in pregnancy, another treatment option for CPPD, and a new guideline on lupus. So let's begin with lupus. A study from Western Australia looked at the incidence of lupus-associated interstitial lung disease. We've talked a lot in September about ILD, not so much about lupus. You know, it's a big deal in scleroderma and in myositis, the MDA5 patients, for instance, and in RA, right? And then, lupus is kind of thrown in. But what's the real incidence? Here, a cohort study of 1,854 patients found that 3.8% had ILD related to lupus. And yes, that was significantly higher than controls, 26-fold higher. I'm not sure what the controls were. But the risk factors for developing ILD in lupus was older age, smoking, and serositis. And not surprisingly, lupus patients with ILD have a significantly higher mortality rate. ILD is a bad player no matter who it shows up in. The Genentech reported the preliminary top-line results of an allegory study. This is a phase 3 trial with obinutuzumab. That's the CD20 monoclonal antibody that's going to be used in lupus nephritis and lupus in general. So this was a phase 3 double-blind, randomized, placebo-controlled, 300 active lupus patients. The outcome was an SRI-4 primary endpoint at week 52. This monoclonal antibody depletes B cells better than rituximab, and in the oncology world looks to be a much better world at treating B cell CD20-related lymphoma especially. So it met all its primary and secondary endpoints. We don't have the actual numbers there, but that's going to be presented in publications soon. As you know, the drug was approved in the last few weeks by the FDA. So at ACR, there was another presentation on a new lupus guideline. Last year was all about the renal lupus guidelines, which were great, helpful, instructive, and debatable, right? Now, Lisa Samaritano, who's led a lot of these guidelines, and thank you, Lisa Samaritano, and your team for all the hard work, she presented the guidelines on basically lupus that's non-renal, so non-renal lupus. And I like the guideline for several reasons, and then I have my but kind of statements. The bottom line is that there were 65 recommendations. Almost all of them were conditional. With low or very low evidence. So there's a real art to managing lupus, right? The three strong recommendations that are evidence-based was, number one, everybody should be on Plaquenil. Number two, everybody should go on prednisone 5 milligrams, but they should be off of or at less than 5 milligrams within 6 months. And number three, therapy should be escalated in people not responding. Number three is kind of like a knucklehead statement, is it not? But then they've got a ton of recommendations by organ systems, neuropsychiatric, articular, skin, etc. And I'll just read for you a few of these. And these are the ones that are conditional and very low evidence, but this is kind of the way you practice. And now the ACR is telling you that what you're doing is good. So asymptomatic neutropenia or asymptomatic lymphopenia, if you have no symptoms, that you do not automatically get an escalation of immunosuppressive therapy. Steroids, biologics, azathioprine, mycophenolate. No. Without other evidence of lupus activity, they conditionally recommend against it. Thrombocytopenia, that's asymptomatic and chronic with platelet counts less than 30,000, they do recommend that you start a steroid with an additional therapy. Mycophenolate, azathioprine, calcineurin inhibitor, CD20, belimumab, and or IVIG, because that must be indicative of lupus activity that needs to be better controlled. Now let's get into thrombocytopenia that is symptomatic, meaning they have active bleeding. They recommend glucocorticoids with either IVIG or an anti-CD20 in addition to conventional therapy. And same for hemolytic anemia. That's symptomatic, meaning ischemic manifestations, etc. The same thing. glucocorticoids with IVIG or an anti-CD20 on top of your baseline background therapy. So it's a good document to hold near, and we do like guidance documents. I think this one was helpful. A report from the journal JAMA Dermatology looked at severe cutaneous reactions associated with allopurinol. So they did a matched cohort study. They found 16 patients with either Stevens-Johnson syndrome or toxic epidermal necrolysis associated with allopurinol use, and they basically assessed these people, and that 16 cohort was matched 1 to 10 with a non-severe cutaneous adverse reaction. They call it a SCARS, 160 patients. And they found that, as we know, HLA-B 5801 is associated with allopurinol-induced severe cutaneous reactions. We know that gene is found in Asians and blacks and less common in the United States. This study, by the way, was done all in the United States. They also found another gene, HLA-A3402, and this had sort of the same amount of risks. But the point of the paper was to say it's not just B5801, but it's this A3402, and then also that it does occur in the United States, more commonly in blacks, and then Asians and then others. But more than a third of people with these cutaneous reactions did not have these genes. So we don't have the complete story yet. And I don't know that based on this data, I would be screening people going on allopurinol for B5801. Asians, I probably would. But nonetheless, I think it's something to think about. A study in IBD looked at infection rates. And I published this because, you know the numbers associated with RA-associated serious infection events, SIEs. The historic number in the pre-biologic era was 9 SIEs per 100 patient years. So out of 100 patients followed for a year with RA on any therapy, 9 would get an SIE. Septic arthritis, sepsis, pneumonia, opportunistic infection even, okay? Then the biologics come along, and we find that the numbers generally run, about 3 to 6 per 100 patient years, less than the historic controls, all right? And we know that when you use really high doses, like higher doses, 10 milligrams per kilogram of infliximab, it goes up to 7 plus. It gets closer to that 9 number. But why do you see lesser numbers in psoriasis and other conditions? And it turns out it's the background condition that determines the baseline rate. So in this study, they show that IBD is like RA. It's what I call a dirty condition. It has a higher baseline risk for these SIEs. So a study of 5,000 IBD patients, and they looked at them, and these are IBD patients that were either had ulcerative colitis or Crohn's disease. Ulcerative colitis, the rate was 5.5. Vedolizumab was 7 per 100. So overall, the number was 5.5. It was higher with vedolizumab. In Crohn's, the SIE rate was, again, still higher than ulcerative colitis, 7.9. And vedolizumab was 6.5. So the question is, do the biologics add to the risk over the background risk of the disease? Maybe a little bit, and only in the worst candidates, and only when you use the highest doses. That's the takeaway and why I reported this one. Another study looked at whether TNF inhibitor exposure in utero would increase the risk of infant serious infections. So a meta-analysis of 10 studies showed that in utero exposure did not increase the infant severe infection rate, and that's 4 clinical trials. And then there were 2 clinical trials looking at breast milk. The mother was taking a TNF inhibitor and also did not show increased rates of infection in the child. Infant vaccinations were unaffected by TNF inhibitor use, but they do recommend BCG if the mother is that BCG vaccination of the infant, which we don't do in the United States, but is done internationally. That should be delayed if the mother is on a TNF inhibitor when the child was being born and whatnot, because BCG is basically a mycobacteria. TNF inhibition would make the child, the infant, at higher risk of disseminated TB. And that's been reported multiple times. So yeah, you don't want to use BCG at the time of birth. But everything else, as far as vaccination, seems okay. Another study looked at claims data on women with inflammatory diseases, IMIDs, that includes both skin, GI, and rheumatology patients. 70,000 patients, 69,000 births, and 7.1% were exposed to at least one TNF inhibitor during pregnancy. And another percentage, half that percentage, was, actually almost the same now. About 6% were exposed to a TNF inhibitor during the postpartum period. They found the TNF inhibition and exposure did not increase SIE risk during pregnancy. Hazard ratios 1.39, confidence intervals 0.95 to 2.0. Not significant, and even lower and not significant for postpartum exposure. So again, good news about how to treat women who become pregnant, and that aggressive treatment of them with biologics, especially TNF inhibitors, appears to be very safe. Okay, so what else we have? We have another pregnancy study that looked at scleroderma, and this is the Swedish birth register that looked at pregnancy outcomes in scleroderma women, 941, who had scleroderma. They had these outcomes after the diagnosis of scleroderma, 941, or within 3 years of diagnosis, that's 39, or before 3 years of diagnosis, that's 839. So they said that overall, scleroderma women have an increased risk of adverse pregnancy outcomes. That's like miscarriage, preterm birth, intrauterine growth retardation. It would include malformations, but there are no malformations here. So they have an increased risk of adverse pregnancy outcomes post-diagnosis. So the diagnosis is already established, the pregnancy happens, they get more APOs. We've seen that in RA, we've seen that in lupus, right? And the outcomes here were mainly preeclampsia, almost 4-fold risk, preterm birth 3-fold risk, C-sections 2.5-fold risk. But they also showed increase in adverse pregnancy outcomes when they were within 3 years of having a diagnosis of scleroderma. This kind of speaks to the point that there's a preterm condition that's stewing before they actually develop clinically manifest scleroderma. And those immunologic abnormalities may translate to higher risk even before you know you have the diagnosis. So interesting. PMR, what's the differential diagnosis of PMR? In my book, it's older Caucasians with stiffness and joint pain, but generally girdle stiffness, acute phase reactants, and did I say stiffness? Did I say older? Did I say white? Okay. And yeah, that's the bulk of the business here, is it not? Yeah, I know you have a patient who's green and not quite 70 years old, but honestly, that's what PMR is. But when it's confused, it's often rheumatoid arthritis, right? In this study from one center, 77 patients referred to rheumatology for possible PMR diagnosis, found that there were several of them, 7%, that had a viral infection, parvovirus B19. What? And these 7% of these patients, so it's like 6 or 7 patients, actually it's 5 or 6 patients, they all had arthralgia, okay? They all had PMR-like symptoms, bilateral neck, shoulder pains with prolonged morning stiffness, low-grade fevers, and high acute phase reactants, sed-rate, and CRP. But none of them had hip pain. It was just upper extremity. Interesting. 4 out of 5 were male. The mean age was 55, less than you would expect for PMR. I put it up because now it's in the differential. I would not have previously assumed that parvovirus B19 could be a possible diagnosis. Oh, and by the way, none of these patients with B19 masquerading as PMR were RF positive or CCP positive. So we worry about aging and the rising risk of osteoarthritis. A recent report from the Global Burden of Disease study, it was in rheumatology, talked about a growing burden for a subset that you wouldn't normally consider, and that's middle-aged adults between 40 and 59 years of age. In recent years, the prevalence of OA in middle-aged adults has risen 124%, from 11.8 million in 1990 to 26 million in 2021. What? 56% of incident cases, 38% of prevalent cases occurred in the middle-age group. This is 70% higher than its occurrence in the elderly over age 60. I find this surprising. But then again, is it really? Why would 40 to 59 be getting it? It's got to be lifestyle. Growing frequency of obesity in our population, and then other lifestyle factors that must be going into this. They did find more of it in high-income individuals. Myositis. Let's talk 2 reports on myositis. A South Korean study of 481 patients looked at myositis-associated cancer, which they found in 12.9%, or 62 out of 481. That's your risk. I've always thought that the risk is highest in males that are older with dermatomyositis. In their analysis, the cancer risk factors were age, older, male, bingo, current smoking, makes sense, and dermatomyositis, and also having TIF1 gamma antibodies. But they also showed a lower risk of cancer in those with the anti-synthetase syndrome, overlap myositis, those with arthritis, and ILD. So they had what they called a SCRIM score, SCRIM, which is a number of factors put together, and it gives you an area under the curve of 0.85, suggesting a high predictive value. You know, maybe we could use this in practice. I think many of you, when you're making a diagnosis of polymyositis, dermatomyositis, are automatically looking for cancer. I don't. I never have. I do health maintenance. You know, I get what they need based on their age. And then if they get other symptoms suggestive of cancer, I'll evaluate it. But you remember at ACR 3 years ago, a plenary session laid down new guidelines on how to develop risk categories. And they had, you know, other than a minimal risk, they were doing really invasive evaluations for cancer that I did not agree with, and they didn't have any data for. They were just throwing it down, hoping that someone's now going to study this. Again, how you handle this is going to be up to you, but we need guidance that's based on data and not just based on strong opinions, like mine, for instance. Another study looked at mortality in dermatomyositis. I worry about dermatomyositis when it gets into the hospital. This is a study of 153 adults with dermatomyositis who were hospitalized, and what were their outcomes? Well, unfortunately, 10% died. 16 out of the 153 died. Risk factors for death from dermatomyositis in the hospital was having a rash, 12-fold higher risk. If you had active DM rashes, 81% versus 34% in those that didn't. Wow. ILD, not surprising. We said ILD is a bad player and poses a high morbid and mortal risk, no matter who. This gave you a 6-fold higher risk. And then an elevated neutrophil to lymphocyte ratio. Most of you don't do that. It's cheap, it's easy, anyone can do it. You have a 29% increase for every 1 unit increase. So it was an elevated NLR was seen in 12.5% of those who died versus 4.9 versus from those who didn't die. So sort of a doubling of risk. Anyway, for me, the worrisome factors when you get admitted to the hospital are admitting features of shortness of breath, ILD, right? Dysphonia, dysphagia. They're now at high risk for aspiration, which is going to worsen their lung outcomes when they already have a risk of ILD, right? And that's pretty much my red flags that were not borne out in this study. I liked another study that this week that we reported on IL-1 inhibition in calcium pyrophosphate deposition disease. I think we had a study from EULAR 3 years ago that was an IL-1 control trial, but it was small. And can you use an IL-1 inhibitor in pseudo-gout or CPPD? Well, this was a meta-analysis of 5 observational studies and 1 randomized controlled trial, a total of 84 patients that used the drug anakinra, the IL-1 inhibitor. And they showed that in patients with acute flares of pseudo-gout, of CPPD or pseudo-gout, that they had positive clinical responses by physicians of 75%, reduction in pain scores by half, significant reductions in CRP levels by 62 points on a 62 milligrams per liter, okay, or 0.6 milligrams per deciliter drop, and a reduced number of joints -5, reduced number of swollen joints -3.6. And as you would expect, other side effects that you see with IL-1 inhibition, injection site reactions, rashes, bacterial pneumonia, and neutropenia are all reported. I think this is a reasonable choice for someone with acute pseudo-gout that hasn't been well controlled on existing therapy. All right, one last report. While we went to ACR, nipocalimab, the FcRn blocker, that's been studied in RA and a few other conditions, has been studied in Sjogren's disease, and that's the Dahlia study. It was reported in Lancet Rheumatology. This was a phase 2 trial of patients with active, moderate to severe, Rho-positive Sjogren's syndrome with a CLIN ESSDAI score of grade of 6 or more. And they were either given placebo or nipocalimab 5 or 15 milligrams per kilogram every 2 weeks for a total of 22 weeks. That was the endpoint. The endpoint was the reduction in the CLIN ESSDAI score. And yes, the higher dose, the 15 milligram dose, not the 5 milligram dose, was associated with significant reduction at week 24. Again, the least squares mean was -2.65, and that was significant at p.0018. This is a positive phase 2 trial. We need to see how they're going to do in phase 3. As you know, we just had the results of ianalumab from Novartis reported at ACR that also gave positive results, but only when they combined 2 different studies together to get positive results at multiple time points. Otherwise, both studies seem to only get positive at the end. All these studies are hampered by high placebo response rates. That's the big problem. So for them to prove with ianalumab, the other B-cell targeted monoclonal antibody, that you can get a significant clinical response along with biologic responses. For instance, this FcRn receptor blocker is supposed to drop autoantibody levels, and it did. Okay, and the same was seen with the dual B-cell inhibitor ianalumab. So if you can show clinical benefit in a phase 3 trial, that's what we want to see. That's what we need. How they're going to be used in practice remains to be seen. So I want to remind you for last week, this week, and the next 2 weeks, we're going to have replays from Room Now Live 2025. That was in February of this year. Last week was on psoriatic arthritis. Next week is on spondylitis, and the last week is going to be on vasculitis. You may want to see these excerpted talks. I think that they're instructive and tell you the quality of what you'll see at Room Now Live in 2026. It's coming. You can register now. Go to roomnow.live. The meeting is February 7th and 8th in Dallas. You can be there virtually if you like. Look at the agenda. Our speakers are fabulous. Tahina Nyoji is talking about disease modification in osteoarthritis. Susan Goodman is going to be talking about perioperative management of RA patients and use of immunosuppressive therapy. Rohit Agrawal is talking about 2 talks on myositis. Again, look at the agenda. You'll want to be there. I want to be there. I have to be there. We'll see you next week. Bye.